So if we look at the 7 most common sports injuries, we'll find that what the sports physician named groin pull comes second after the ankle sprain, in front or above many common sports injuries like the knee, ACL, and patellofemoral pain and tennis elbow and things like this. A growing interest in the whole world had been developed over the last 10 years, studying what's the main causes of groin pain. There is a lot of confusions, a lot of problems, a lot of dilemmas concerning this, like the many anatomical structures lying in the groin area, the abnormal findings in asymptomatic patients, as well as the heterogeneous taxonomy. In a systematic view, studying the treatment of groin pain in athletes, they found that in 72 studies, they used 33 different diagnostic terms. And that's why the whole world and a numerous group has developed a new systems or a new consensus groups to study these things. It started in 2015, where the Aspitar group in Doha, in Qatar, they started developing a consensus meeting. And that was in 2015, and they studied the proper taxonomy or the proper terms for injuries in these areas. And they divided the groin pain in athletes into 2 different categories, three major categories. One, clinical entities, and then hip-related problems and other causes. If we look at the defined clinical entities, we will find that they divided into 4 areas: pubic-related pain, adductor-related pain, inguinal area-related pain, and iliopsoas-related pain. These are the 4 what they named defined clinical entities. They stressed on the clinical examination to differentiate between or to define which one apart from the other. So at the pubic area, you will feel a tenderness, pain provocative, special precise palpation in the area of the symphysis and the adjacent pubic bones. Adductor, it's on the adductor tendon and aggravated by resisted adduction, inguinal over the inguinal canal region, and iliopsoas in front of the flexors of the hip. So these are all simulated or stimulated by pain, precise tenderness points. If we think about the pathology of each area, the pubic-related pain, this is an imbalance or an abnormality between the hanging powers of the anterior pelvis, between the abdominal muscles, especially the rectus abdominis, and the adductors of the hip. So if you have an imbalance between these 2 powers, like a strain in one area and overpower against the other one, you will find the hypermobility of the symphysis and pain of the pubic-related groin pain. Adductor-related pain, this muscle has special pathology or a special anatomical shape, that it has a sheath or aponeurosis that is going around the muscles till its insertion. So this muscle especially is at susceptibility or high susceptibility for injury of its aponeurosis. If we look at the literature regarding the treatment, we will find that they put the pubic and the adductor-related pains in one entity regarding the treatment. There is a limited evidence regarding the specific or the perfect treatment for this. But if we look at the literature, we will find that there is a level 1 evidence that physiotherapy, especially supervised active physical therapy, has a success up to 75%. Adjunct therapy like shockwave and things may help in rapid recovery. However, in refractory cases, there is a level 2 evidence that partial surgical release, only release of the adductor aponeurosis of the adductor longus leads to good results. If we think about the inguinal related pain, traditionally, this is people or surgeons thought of it as a hernia, as a type of hernia. However, there is no specific hernia. So other people think about it as a neuroma, like a neuroma or entrapment in the ilioinguinal, genitofemoral or iliohypogastric nerves. Many nerves passes through the inguinal canal. Gardhart in 2020 has suggested a new pathology or a combined mechanism that there is a muscle imbalance leading to microtrauma of the fascia transversalis and weakness of the posterior inguinal wall that leads to bulging of the abdominal structures. These bulging of the abdominal structures will compress the nerves, so it's a combined mechanism between a weakness of the posterior wall of the inguinal canal together with an entraped or a neuroma. So, surgeons or general surgeons, there is a limited evidence again of what we should do for this, what we name the inguinal related pain or sports hernia. The standard is laparoscopic repair or augmentation of the posterior wall of the inguinal canal together with a neurolysis. However, some thought about non-surgical treatment. It gives 50% like the injections or the physiotherapy. Iliopsoas related pain, Dr. Manliu covered a lot of it. So the iliopsoas muscle, it's a special muscle with a special configuration. It's a confluence of two muscles. It has a long obtuse curve, so it's not straight. It comes from the iliac fossa down to the lesser trochanter with an obtuse course, and it's hinged on two pulleys, a static pulley and a dynamic pulley. The static pulley is the pelvic eminence. However, the big pulley is the femoral head, and that's why it has a special configuration. Again, this makes it very liable to injury, tendinitis, snapping, fibrosis in this area. There is a limited evidence on which is the best treatment method for it. The non-surgical proponents assume or says that the surgery will weaken the power. However, surgical proponents says that it's always associated with an intra-articular pathology, especially labral tears at 3 o'clock, what we name the iliopsoas impingement syndrome, or the most anterior labral tear at 3 o'clock, just beneath the iliopsoas tendon. So this video, they will find a congestion in the area of the iliopsoas tendon of the capsule, together with a pathology or some congestion of the anterior labrum just beneath the iliopsoas tendon. So in our experience, we release it at the central compartment. This is a video of the release. I won't go through it again. So this is our experience after looking at our patient that we released the iliopsoas. That was 5 years ago. We looked at 16 patients, and we used the dynamometer to see whether this results in weakness after 6 months or not. You can see one of our patients, there is no weakness after 6 months in our results. If we look at the hip-related pain, you have to differentiate them into two categories. The red flags, the most apparent to every surgeon, which is like an avulsion of the anterior inferior iliac spine, like a fracture of the neck, like a Perthes disease. The big things, you should not miss them. However, the non-red flags condition, these are the hidden areas. Everybody can miss them because they are defined by using special tests. In 2018, in Zurich, in Switzerland, a consensus meeting again was held to differentiate what we name the hip-related problem, to classify, define, and diagnose the non-red flag, the hidden hip-related pain. And they defined that the most common conditions that we go through, which is hidden, named the femoroacetabular impingement, as well as the acetabular dysplasia. The other things comes with that there is a soft tissue injury like a labral tear without a distinct osseous abnormality. A femoroacetabular impingement, they define it as a motion-related disorder due to premature contact between the femur and the acetabulum. And we all know that there is 3 types: CAM, which is abnormality of the femur; pincer, abnormality of the acetabular overcoverage, and a combined mechanism of them. They defined 3 things, a triad of diagnosis, which is a typical symptoms: pain in the groin, but sometimes it's pain in the back or the buttocks. Mainly, they present with an anterior hip pain or a groin pain, plus a clinical signs like positive anterior impingement test, flexion, abduction, internal rotation, and a typical radiographic findings. The second comes in the most common things for hip related is dysplasia, which is a misalignment or an abnormality between, or an incongruency between the femoral head and the acetabulum due to abnormality of its shape or the size of the orientation. And the same diagnostic triad appears or is present for treatment of, for diagnosis of dysplasia, which is typical symptoms, provocative tests, as well as radiographic signs. You have to have the three to diagnose them. The pathology for the the pathology for the under coverage, or what we name the hip dysplasia, is that you have an overload in a limited surface area. That will lead to an overload in the soft tissues. That will lead to an overload in the soft tissue, namely the labrum, leading to hypertrophy of the labrum, and the capsule, leading to further tearing and a pathology in them. So the radiographic appearance, you will find that there is a deficient acetabulum under high grade, like a stabular central edge angle less than 10 degrees, and a low grade between 10 to 25, and an over coverage, which is an acetabular central edge angle over 40, which is a pincer or an over coverage or a femoroacetabular impingement. The radiographic findings, you have to look for the alpha angle increase in the AP view or the lateral view, typical of CAM deformity. The most diagnostic method is to do an MR arthrography, a combined special sequence of radial oblique sequence together with an injection of a dye to fill the defects, to show you if you have a chondral delamination or a labral tear. So in conclusion, groin pain in athletes, it's a complex entity. It requires a multidisciplinary approach. You have to have a very good radiologist, a very good general surgeon or a general practitioner to see the clinical entities away from the orthopedic entities. Pain tender point or pain provocative palpation is very useful to differentiate the four clinical entities: the symphysial related pain, the adductor related pain, the inguinal related pain, or the iliopsoas related pain. Hip pain is commonly used, is commonly diagnosed as femoroacetabular impingement and dysplasia. The triad of diagnosis for hip related pain are three things: symptoms, signs, and typical radiographic findings. Thank you.